Ada, doktor.
Kalau macam ni, ada gema tak? Saya pula.
Okey, doktor.
Okey. Okey ke?
Okey, doktor.
Alright. Sekejap Sorry. Nampak kan? Yang ni the best lah. I boleh. Yang ni pun dah the best kamera lah ni. Ikut iPhone lah ni. Nampak tak? Nampak my hand? Nampak
Nampak, doktor.
Alright. Okay. Assalamualaikum warahmatullahi wabarakatuh. Let's continue our lecture or practical session today with Umul Kitab Al-Fatihah. Alright. Okay, today I'm going to talk about the airway management. Basically, I will show you some live video regarding all the device, every equipment that available in emergency department. Basically, I will talk about the oxygen supplemental therapy, which is consists of we have a nasal prong. You can see this one, nasal prong, right? Alright, this one nasal prong. What the indication for the patient who need for a nasal prong? The indication for oxygen supplement with the nasal prong. Ada boleh jawab tak? Macam saya my lecture before, my lecture just now, this morning. So for the indication for oxygen supplemental therapy, which is SpO2 maintain, gema lagi alright, okay. The SpO2 cannot maintain the more than 95%. So we can use this nasal prong in order to give the oxygen therapy for this patient. Okay, alright. So how much you can give the oxygen, FiO2? How much for the nasal prong? What the maximum FiO2 you can give? You can provide with nasal prong?
3 to 5.
3 to 5 liters per minute. Alright, that one is concentration. It's not that one is flow. How much flow that we can give? This one I ask regarding the FiO2, which is partial pressure oxygen that we can give to the patient, the maximum that we can give through nasal prong. How many percent oxygen we can give? The maximum concentration of oxygen.
40%.
40%. Alright. Hampir. Any guess? So how much ni kita punya percentage under room air? Under berair berapa oxygen concentration?
21%.
21%, alright. Then one patient on nasal prong, the maximum FiO2 we can give is 60%. Alright. Why 60? Gas. Alright. I think 40% is betul lah, 40%. So every 1 liter you can increase 3 to 4%. So maximum you can give is 6 liter through Nesoprom. So 6 liter darab dengan 3, 18%, right? 6 liter times 3 to 4 ataupun 3 is 18. If times 4 is about 24, right? So plus dengan 21, the maximum you can give about 38 to 44%. So you will increase every 1 liter you will increase about 3 to 4% from concentration from room temperature. Room temperature pula. Ni daripada our punya air, room air. Alright. Okay. Why we cannot give more than 6 liter? What's the complication of Nesoprom? Siapa boleh beritahu? So basically, when we give more than 6 liter, we can cause dryness of mucosa. So in spite of you increase the FiO2, you give the complication to the patient lah, such as macam ulcer, mucosa dryness, patient discomfort. So if you give more than 6, you doesn't increase the concentration of oxygen much. Even though even you give the complication to the patient. If patient need more than 6 liter, you can change to this one. What is this? Siapa boleh guess? Apa nama lain face mask? Balik kan? Tak apalah. I think tak apalah terbalik. You can imagine, right? Alright. What are the name of face mask? So Hudson mask. You have a Hudson mask. Face mask dengan Hudson mask sama. So you akan nampak, right, this one. You akan nampak vented punya valve, right? This one is a two-way valve. When you inhale and exhale, actually you mix with the oxygen concentration that you give. That's why you cannot give the maximum oxygen, because of this rebreathing system. You have the rebreathing system mask. This one is a rebreathing. You have the two-way valve, left side and right side. Alright, and then you can give the oxygen to this tube, and then when you inhale and exhale, you can mix with the oxygen concentration and also room air. Then that's why you can give doesn't give a maximum concentration of oxygen, because of face mask apply the rebreathing punya system. Alright. So berapa concentration that you can give maximum for face mask? Berapa liters?
Five to 14
liters.
Jap. Ke 5 to 10? 5 to 10 rasanya.
Alright. About that lah. 6 to 10 liters. Alright. So maximum you can give is 60%. Alright. Sebab apa? Sebab dia takkan more than 60, because of they apply rebreathing punya system. Alright. So next you go to venturi mask. This one is a venturi mask. So apa yang special dengan venturi mask? Venturi mask apply apply rebreathing or non-rebreathing punya sistem. Kalau you boleh tengok, kalau ikut logik lah. Rebreathing or non-rebreathing system. Siapa boleh guess?
Rebreathing.
Rebreathing punya system. Because of we have a valve here, two-way valve, inhale and exhale. Alright, and then we have a connector, and then connector akan bersambung dengan ventri valve. This one is ventri valve. Siapa tahu berapa persen? Ada berapa persen? Ada berapa jenis ventri mask? Apa color ventri venturi punya valve punya? Ada berapa color? How to differentiate? Kenapa dia ada color coding? Why? Why?
Because different concentration.
Yes, different concentration of oxygen. Which one is lowest? Ingat tak? Kalau you kat sini, you akan tengok lah kat sini. IT tak nampak kot, nampak tak? Tak, memang tak nampak lah. Dekat sini ada tulis yang blue is the lowest, 24%. Blue the lowest, and then we have 60%, we have 28%, 24%, 28%, we have 35%, 40%, and then this one is 60%. Alright. You notice apa membezakan antara the highest and the lowest? What you notice?
Size of valve.
Yes, the size of valve. The highest, the size of valve will be small, but the lowest one is the valve. The size of valve will be bigger lah. The biggest one, the biggest valve dekat yang lowest punya concentration. Alright. Daripada sini dia ada juga dia akan bagi tahu 24% dengan 4 liters per minute of oxygen. Kalau 60%, you need to give 15 liters per minute of oxygen. Okay, alright. Siapa tahu what's principle that the ventri valve apply? What principle? Tersangkut Gambar tak gerak Gambar tak gerak? Gerak.
Gerak tak saya?
Gerak. Alright. So, what they apply which principle? Siapa pandai fizik kat sini? Siapa pandai fizik? Saya tahu. Bernoulli principle. Alright. Apa yang Bernoulli principle tell us? Tak ingat? Dia balik baca Bernoulli principle. Basically akan bagi airflow lah inside dia punya venturi valve. Kita akan connect to the oxygen supply and then give dia punya airflow. Semakin laju airflow, dia akan create the sucking effect lah, sucking punya pressure. That's why dia punya oxygen from the room air, dia akan masuk ikut kita punya valve ni. Selagi lagi besar valve, lagi banyak air ataupun room air, dia akan sucking into the venturi valve and then lead to a lot of mixture of room air into dia punya venturi mass. So lagi kecil, so dia akan less oxygen sucking into the venturi valve. Alright, dengar ke ni? Bising sikit. Ada announcement. Alright. Sekejap Alright. So my apa panggil? Homework hari tu. Siapa cari? Ada indication for venturi mass for COPD patient, right? Betul ke? So venturi mass is for COPD patient. Siapa cari hari tu? Yang masa PBL, yang oxygen therapy. Why we need to give COPD patient ni low concentration of oxygen? Why? Siapa yang hari tu?
Me, doktor.
Yang cari? Siapa yang ni? Syamina. Alright, Syamina, can you explain why?
Tak ingat lah plan tu.
Tak ingat?
Apa term yang hari tu yang doktor sebut?
Apa? Hypoxic drive?
Itu.
Saya tak beritahu hypoxic drive tu. Saya ada beritahu tapi saya tak. Hypoxic drive is not the answer.
Haldane effect tu kan.
Alright. Ikhwan. Can you explain the Haldane effect?
Bila apa? Partial pressure of oxygen tu tinggi.
Tak dengar. Dekatkan sikit dengan
When high partial pressure of oxygen, so oxygen will bind to the hemoglobin. So it become oxyhemoglobin. So oxyhemoglobin ni will bind poorly to the carbon dioxide compared to the oxyhemoglobin. So maksudnya for the same amount of carbon dioxide in blood, more apa? Hemoglobin more dissolved in plasma. So dia daripada dia bound dekat hemoglobin tu kan cause hypercapnia.
Alright. Okay, nak dekat dah. Siapa cari lagi? Ada. Can you explain about Haldane effect? Betul dah tu, Ikhwan. Ada sikit. Dah nampak dah. And then ada siapa-siapa lagi cari about the Haldane effect? Lukman boleh?
Not quite sure ada.
Tak sure. Siapa siapa lagi? Boleh bantu. Anis Amira.
Not sure, Doktor.
Tak sure. Semua tak sure. Saya dah bagi homework dah hari tu. So
Video smash je Doktor.
Ikhwan. Al-Hakim.
Is it the COPD patient already in hypoxic? So we need to maintain the hypoxic state in COPD patient.
Hypoxic drive lah, you mean? Okay. There's a theory lah basically. Before this, memang we think that hypoxic drive can lead to reduce ataupun depress the respiratory rate that lead to increase the CO2 retention lah. Basically, that one is a myth. So basically, they explain that COPD patient ni dia punya oxygen dia punya carbon monoxide is very high lah. Exposed on the high, dia punya state of carbon dioxide pressure of the carbon dioxide is very high because of chronic lung disease, right? So basically, when the PCO2 is high, the affinity partial pressure PCO2 is high, but partial pressure of the oxygen is low. So the affinity to bind to the hemoglobin is which one is higher? Higher concentration will increase the affinity to bind to hemoglobin. And then if patient that we give this patient more higher concentration of oxygen, so in Haldane effect, the affinity of oxygen is higher than carbon dioxide to bind to hemoglobin. So when you give the higher concentration of oxygen, basically hemoglobin will increase the affinity to bind to oxygen that we give just now, and then we will displace ataupun we replace the oxygen, we replace the carbon dioxide, and then lead to increase the concentration of carbon dioxide in the bloodstream because of oxygen dia punya replace the carbon dioxide punya binding to the hemoglobin. That's why PCO2 is increased in COPD patient. There's one theory. The second theory, because of VQ mismatch lah, because of pulmonary vasoconstriction, because of our pulmonary artery will vasoconstrict when the oxygen is higher, the concentration of oxygen is lower. When we give the oxygen, dia akan reverse. So reverse, dia akan vasodilate. So pulmonary vasodilatation. And then if reverse, that lead to increased VQ mismatch. That's why CO2 will be higher in patient that COPD patient that receive higher concentration of oxygen. So kita boleh explain two reason lah why CO2 retention is why COPD patient cannot receive higher concentration of oxygen because of Haldane effect and also VQ mismatch. Alright. Okay. We move to the high flow mass lah. We move to the high flow mass punya oxygen. So high flow mass basically what the difference between the Hudson mass dengan high flow mass. This one is Hudson mass. This one high flow mass. Apa yang you notice the difference? Ni apa ni? Bag. Yes, oxygen bag. So oxygen bag is dia punya function adalah to save panggil for oxygen reservoir lah. When you connect to oxygen, the oxygen will accumulate inside the bag and then lead to increase the oxygen reservoir. And then that one is a dia punya satu dia punya difference adalah ada oxygen reservoir ataupun bag. The second difference is saya dah tunjuk dah tu. Nampak tak tau ni? Apa dia?
Non-rebreathing system.
Non-rebreathing system. Why? Why you said it's a non-rebreathing system?
Close hole.
Alright. There's a one-way valve lah. Basically one-way valve. Dia boleh buka ni. Alright. Tuan nampak hole, right? And then ni yang valve dia. So when you inhale, you akan take all the oxygen from the bag. Alright? Because of kat sini ada satu lagi valve. Ni saya tunjuk. Alright. One way valve. This one also one way valve. So when you inhale, you will take all the oxygen inside the bag, and then when you exhale, yang ni akan tertutup, and then oxygen that you the air that you exhale tu will akan keluar through this one way valve. Alright. So you takkan ada the mixture of oxygen inside the oxygen reservoir. So you always give the oxygen 100% to the patient because no mixture of oxygen with the room air. This a non-rebreathing mask, which is high flow mask lah. Alright. So what the maximum you can give the FiO2 concentration using the high flow mask? Berapa?
15.
Yes, 15 liters. And then dia punya concentration of the oxygen FiO2 dia berapa? You can give up to 96% lah. Because of what? Because of usually sometimes dia punya ni mask tak properly seal. So something ada leaking lah. Dia punya surrounding the mask ni. That's why dia ada elements of mixture of air with the oxygen. That's why you cannot give the high 100% oxygen. It depend on you how effective you seal the mask with contact to the patient lah. Alright. Okay. So there's a oxygen supplemental oxygen lah. Supplemental oxygen. So this one, yang ni apa ni? Nampak tak? Boleh nampak? Tak boleh nak ni sebab kamera saya tak gerak. Tak boleh nak zoom out. Nampak? Alright. Ni apa?
Ventilator push back ke ambu bag?
Ambu bag is a brand name. Okay, apa yang nama dia? Nama sebenar dia. Yes, and then alright. Okay, senang je nak ingat. You nampak this one is what? Bag. Right. This one bag lah. And then this one is valve. And then this one is a mask lah. So bag, valve, mask. Alright. So bag, valve, mask. So bag, valve, mask. Alright. Okay. Dia punya anatomy of bag, valve, mask adalah we have a reservoir, oxygen reservoir, which is connected to the bag. This one is bag, and then this one connector, and then this one is an oxygen bag, which is oxygen reservoir. Alright. Yang ni tak ada function apa-apa kecuali dekat sini lah. Kat sini ada oxygen connector. You need to connect the oxygen supply through this one. Alright. And then after that, dia punya reservoir dia akan kembang lah kat sini, expand. And then this one is a one-way valve. Ada kat sini one-way valve. In order why one-way valve? Because of they apply the non-rebreathing punya system juga. And then we have the bag. So we have bag. So berapa liters the maximum when you bagging? Kalau you bagging maximum berapa? Kalau you bagging and then you try to keluarkan semua all the volume inside the try to keluarkan all the volume inside the bag. Berapa punya volume maximum?
15 ke tak?
15 apa tu?
Room air kan?
Bukan, volume.
15 liter?
Volume dalam ni.
Oh,
So volume about 1.5 liters.
wow.
Alright, 1.5 liters. Yeah. So basically when you bag, kita punya tidal volume berapa? How much? Our tidal volume. Hari tu saya ajar kan ventilator. Tak ingat dah. Tidal volume.
Around 500 milliliter, tak tahu.
500. Tapi berapa liter, berapa mil per kilogram?
Is it 7, tak tahu, 7 mil.
7. Alright. Safe punya answer. Okay, 6 to 8 mil per kg. Kg tu ideal body weight. So kalau saya dalam 60 contohlah, 60 ideal body weight ideal body weight 60, darab dengan 8 about 480, right? 480. So dalam ni ada 1.5 liters. So macam berapa, how much yang kita nak kena bagging? You need to rapat macam ni untuk give the tidal volume. One tidal volume, you kata the maximum basically you give about 500, right? So you need to give 1/3 lah from this volume. So basically kena macam tu je, jangan rapat sangat, right? This is the correct way lah, jangan rapat macam ni. Kalau you rapat macam ni, you tend to give about 1 liter. Basically you need to give 1/3 from this volume. Macam tu je. Alright. What happen that when we give more than necessary? Kalau high tidal volume kali tu, ventilator kelas saya dah ajar dah. Apa? Ventilator ni. Ventilator induced lung injury. Ada berapa dalam tu? Ini sebab quarantine ke apa ni? Tak ingat semua kelas. So apa? The question, what happened that when we give more than 500 liters? You know the ideal tidal volume is 500, and then you bagging half of this volume and then you tend to give 1 liter. What happened? What the complication you can give to the patient when you give more tidal volume?
It can cause VALI, ventilator assisted lung injury.
The patient tak intubate lagi.
Oh,
Patient tak on ventilator lagi. Tapi the concept is similar lah. The concept is similar basically. When you give the more tidal volume, you can give barotrauma or volume trauma to the patient. Possible patient can lead to pneumothorax. Dia punya alveolus can rupture and then lead to pneumothorax because you give more tidal volume. The correct way is you need to give 1/3 from this volume. 1.5 liters you need to give like this. Alright. Okay, barotrauma, volume trauma, pneumothorax, you can boleh bagi tahu lah that is a complication of back valve mask ventilation. Alright. Okay, we go to valve. Ni apa ni? Yang ni adalah top of valve. Maksudnya dia akan prevent from barotrauma lah basically. Basically you need to give PEEP, right? This one you can control PEEP. Apa maksud PEEP? Positive and expiratory pressure, right? Alright. When you give more tidal volume, dia akan tend to increase PEEP lah, because more air accumulate inside the lung. This one, pop off valve ni, basically dia equalize the pressure. So in order to prevent barotrauma, volume trauma, dia akan equalize the pressure. What we set lah, the maximum that we set about 5 mil, 5 oxygen, 5 water pressure, 5 water pressure PEEP. You set, and then once you bagi, dia akan equalize to 5. So kalau any pressure more than 5, dia akan keluar macam ni, dia akan equalize the pressure lah, this one. So make sure this one is correctly set lah. Alright. Dia ada open and close. You need to open. Alright. Ada button ni ada tulis open and close. You need to open the button, pop up button. Pop off button. Pop off punya valve ni, open. Alright, this one is a 1-way valve. Ni akan nampak kan valve. Nampak tak? Saya pun nak. Tu yang nampak. When you give the you give the positive pressure, basically the valve will be open, right? Okay, make sure this one valve, this one mask. So you have a airway orifice, and then this one the hard shell, and then this one is yang soft punya part of the mask lah. So basically untuk soft part ni, basically dia why soft, because of dia nak properly fit into the surface of patient punya skin. So in order to prevent leaking. Alright. Okay. So you tahu the indication of back valve mask. Basically you can give the oxygen without bagging. When you give the oxygen without bagging, you just sambung, connect to the oxygen supply, and then you give like a high flow mask. Without bagging, you give the high flow mask, and then this one is more higher concentration. You can up to 100% if you properly place the mask on the patient punya face. If no leaking, you can give up to 100% without begging. So bed bath mask can be a function as a oxygen supplemental therapy. Alright, when you begging, actually you give the positive pressure ventilation. In patient like apnea, ventilation problem, ventilatory punya problem, type 2 respiratory failure, GCS low, sometime during pre-intubation, you need to give positive airway ventilation. So you can give the function is, first is oxygen supplemental therapy, and second one you can give the positive airway ventilation to the patient. It's very life-saving punya procedure. You need to prepare bed bath mask because of when you cannot intubate, you can ventilating through bed bath mask, right? Okay, and then complication like barotrauma, volume trauma, pneumothorax. Patient can have a stacking breath. Stacking breath is when you give a lot of ventilation. When you give hyperventilation to the patient, you can create the stacking breath. So make sure you dia punya tidal volume, make sure you bagging about 1/3 from this volume, and then every 6 seconds. Every 6 seconds you bag one, and then you kira, you count 1001, 1002, 1003, 1004, 1005 bagging, and then 1001, 1002, 1003, 1004, 1005 and bagging, in order to prevent hyperventilation. Alright? Okay. Apa lagi ya? The factors that factors that affecting the ineffective embo bagging. Alright. So the first one, when you embo bag, you need to make sure the airway is patterned. So kalau you bagging when the airway is not patterned, it doesn't work. So make sure you open up the airway, and then you open up the airway. You need to, if airway cannot maintain, you need to have this one what? Apa tak? Ni apa ni? Tidur ke? Dengar ke?
Dengar.
Alright.
Oropharyngeal and nasopharyngeal airway.
Opa mana opa? Yang mana?
Yang opa yang tu.
Alright. Yang ni nasopharyngeal airway. Pernah keluar last punya batch. So macam-macam keluar. Yang ni nasopharyngeal airway. Ada bagi tahu ETT lah. Apa lagi? Ada banyak benda lah dia bagi, ikut dia suka dia nak bagi apa. Alright. So you need to recognize this lah. This one airway adjuncts. So you have the OPA and also nasopharyngeal airway. So OPA, how to measure heart to heart and soft to soft. Kalau heart to heart, incisor to angle of mandible. Soft to soft, angle of the mouth to tragus. Alright. Yang ni based on nasopharyngeal airway, based on our little finger. This one our little finger, this one patient punya little finger, bukan doctors punya little finger. Okay, patient. Kalau saya patient, yang ni possible is smaller lah. So it's not correct size. You need to measure the little finger of the patient is similar to the size of nasopharyngeal airway. Alright. So how to insert? Basically we have two methods. First method is, siapa tahu? Ibrahim tahu tak Ibrahim? Do you know how to insert nasopharyngeal airway? Not nasopharyngeal, oropharyngeal airway. How to insert? Yes, the correct size. Okay, I already measured. This one is the correct size of the patient. This size is correct, already correct. And then how to insert? Alright. Okay. So kalau ni mulut patient lah. Alright, yang nampak right. This one yang dekat above our my index finger is nose. Yang ni lower lip lah. Basically ni lower lip, this one upper lip. Alright, how to insert adalah first make sure tip ni upward. Macam ni. And then insert until you touch on hard palate. Sampai dekat hard palate, you rotate about 180 degree. And then you insert. And then you you insert a bit. You insert, and then this one will be land on the back of the tongue. Alright. So this is the first technique. Second technique, actually you need to have a tongue depressor. You ambil tongue depressor, you depress the tongue, and then how to insert is just follow the contour of dia punya the shape of the tongue. So basically the tip is downward. And then you depress the tongue using the tongue depressor, and then you insert. Okay, boleh imagine, right? So make sure before you insert, you need to check
Gut reflex.
Yes, very good. Gut reflex. So if you have a gut reflex, if patient have a gut reflex, there is a contraindication to insert oropharyngeal airway. Why? Because of patient, we can induce gag and then lead to vomiting and then aspiration. Alright. For this one pula. So basically, for nasopharyngeal airway, how you insert adalah you must be first gentle lah. And then this one, you tahu kan? This one is a bevel ataupun tip of the nasopharyngeal punya airway adjuncts. Basically dia punya bevel ni should be outside, lateral to the patient, nostril. Kalau macam mana nak tulis? Ni kalau ni lah. Ni patient punya nostril. This one left side lah, patient punya nostril. Right. So make sure susah ni nak orientation ni. Dah lah terbalik gambar. So basically yang ni lateral part lah of the nostril. This one is a medial part. Yang ni. This one is medial. This one is lateral. Boleh faham? Boleh ke? Boleh. Alright. So you insert lah. And then you kena clockwise and anti-clockwise. You insert gently, gentle, be gentle lah. Masuk. If you have a restriction ataupun limitation, you need to change to another nostril. Make sure you change lah. And then you change. Kalau sebelah sana, you akan rotate. Make sure dia punya bevel ni, yang ni at the medial part, this one is lateral part. Alright. Okay. And then you insert, rotate 90 degree, anti-clockwise and then clockwise, and then until you insert. Alright. Tu je, senang je. The contraindication adalah patient yang we suspected basal skull fracture. When evidence of basal skull fracture, contoh ada apa? Raccoon's eye, ada combat sign, ada rhinorrhea keluar daripada telinga dia, ear canal. So there's a sign of basal skull fracture. You cannot insert this one, right? And then if ada epistaxis macam massive epistaxis, post trauma, there's one of the contraindication. Alright, any questions so far? So far so good. Okay, I hope you can imagine lah. Susah juga saya nak ajar kalau ikut kita punya ni. So far okay ke?
Doktor, yang kita kena check get reflex tu untuk yang OPA je?
Yes, OPA sahaja.
Okay.
Alright. For nasopharyngeal, there is no contraindication. Even patient don't have get reflex, you can insert nasopharyngeal. It doesn't matter. You have get reflex or not, you can insert nasopharyngeal. Tapi untuk OPA, you need to check get reflex. Okay? Okay ke? So far so good?
Okay, doktor.
Alright, we go to lecture pula boleh? Okay, so I'm done with the Airway punya practical. I think untuk how you intubate tu, macam mana nak intubate, I think we cannot susah cannot afford to do through online lah basically. So I hope you can learn that technique during your NS posting. Hopefully. Okay ke? Ke you want to additional punya class? Susah I tak tahu nak buat bila lagi.
Buat time DLS okay.
During DLS boleh. Nanti I try to get the punya mannequin.
Okay.
Hopefully you can intubate lah. Try to intubate the patient during DLS. Alright. I'll try to get the mannequin lah. Alright.
Thank you, doctor.
Okay, I will share you a slide. My presentation. Tak nampak Nampak tak? Ni nampak tak?
Nampak, doktor?
Nampak, doktor.
Nampak. Alright. Okay. So basically nanti I share sikit mana tadi. Ni oxygen delivering device. So I dah Akbar. Sekejap I nak kena pergi ni ambil charger, tapi tak sempat. Alright. Boleh dengar
Boleh doktor.
Boleh, alright. Okay, basically we have a oxygen delivery device. So this one already explained just now. Alright, we go the source of oxygen, flow rate, and also FiO2. Positive pressure ventilation using back vast ventilation. And then this one, how you seal the face mask on the patient. Basically, we have put dia punya caudal part. This one is caudal part, and also this one is a cephalic punya part lah. Basically, how you want to seal this patient? When patient ada leaking, you need to elevate the caudal part of the mask, this mask, to make sure dia punya lateral part of this soft part of mask ni will properly seal. When you put on the mandible, you cannot seal properly. If you put just above the mandible, just lower lip of the patient, lower lip of the ni punya ni, you can properly seal. Alright. So untuk back mask ventilation, basically you have one operator. When the one who operate ataupun you ventilate the patient, you need to give this hand grip lah, basically CE clamp. You can see right there, when you hold the mask using your thumb and also an index finger like a C, and then you elevate the mandible from the using the middle ring and also little finger, you elevate into the mask in order to properly seal. Alright. This one is one operator technique. You have a 2% ventilation technique, which is you give the double CE clamp, and then let the second operator to give the ventilation. Alright. And then this one is another option for 2% back mask ventilation. You can use a mask grip technique using your thumb and also hypothenar muscle, and then using the thumb, and then you grip, and then you elevate the mandible using all four punya fingers from the index until the little finger. Elevate the mandible into the mask. Alright. This one is cricoid pressure. When cricoid pressure actually difference with the BURP punya maneuver. What's the difference? First adalah the anatomy that we give a pressure. First, we give the pressure on the cricoid cartilage. Alright. Cricoid pressure, also known as the Silic maneuver, applied on the cricoid cartilage. Okay, using the thumb and index finger, apply the cricoid pressure, and then in order to close the esophagus underneath punya cricoid. So actually, the cricoid pressure in some study it doesn't have anything because of previous study said that cricoid pressure can prevent aspiration. However, in our recent study shown that there is not standard practice, and then it does not prevent the aspiration. Alright. So basically we don't do as a standard practice, and then we do only when we suspect this patient possible having aspiration. Alright, this one is a burp maneuver. We can use by either using bi-manual, which is one operator. yang intubator, which is intubating punya operator use either because of bimanual is a 1% technique and then 2% technique. You need to give pressure, which is you need to backward, upward, rightward, and give the pressure in order to visualize ataupun to expose the cord at the direct laryngoscope. Alright. So how you intubate? So this one, when you want to intubate, you need to prepare for intubation. Basically, yang first punya slide adalah you need to prepare adalah position and then airway maneuver. You need to prepare airway equipment. You need to prepare for oxygen supplement, and then you need to prepare back valve mask equipment. You need to prepare LNA in case of failed intubation, and then you need to prepare for intubation lah. Basically all the equipment for airway for intubate. Alright. So for anatomy, this one is, remember, difficult intubation, lemon. As I said earlier this morning, you need to remember lemon punya mnemonics, which is how you to predict this patient is a difficult airway. First, you look externally, you evaluate 332 rule. You need to measure the Malampati punya scale, any sign of obstruction ataupun obesity, and then neck mobility lah, basically. Alright. This one is a laryngoscope. We have the Macintosh. This one Macintosh is a brand name. Basically, the correct punya laryngoscope adalah curved blade ataupun curved blade lah, hyperacute blade. So the curved blade is the generic name. Untuk brand name adalah Macintosh. So Macintosh punya blade adalah ada size 3 and size 4. Alright. This one is a Miller straight blade. Basically dia is a company punya brand lah. Kenapa Miller? Because of brand name. The correct punya name adalah straight blade, curved blade and straight blade. Alright, sama. So how you open up the mouth? Basically, when you open up the mouth, you need to use a cross finger mouth opening technique. So which one is better? Dia punya grip dia. Kalau you tolak guna macam ni, macam ni. Kalau you tolak macam ni, dia punya ni is not so strong. Kalau you buat macam ni, very strong. Nanti you try which one is stronger. Either you this technique buka macam ni ataupun cross finger punya mouth opening technique. Alright. So this one is position. How you position patient for intubation? Basically, you need to put patient in sniffing position, which is flex the neck, and then hyperextend the head. Alright. Basically, you need to put the tracheus similar level with the sternal punya angle. Sternal angle, this one, sternal angle is similar or at the level of tracheus. Alright. Okay. This is a correct technique. So you need to have a padding. Either use a towel, you use a bed sheet, anything. As long as you put in patient in sniffing position. Alright. Why you put this patient in sniffing position? Because of you need to elevate the vocal cord at the same level with sternum. Kalau you nampak kat sini, the angle. Kalau yang ni, angle dia besar sikit. That's why you can visualize the vocal cord. This one is very difficult, about 90 degree punya angle. That's why when you elevate the punya tongue and everything, it's very difficult. Alright. Alright, this one is a sniffing position. Patient put in sniffing position. It's very, it's just illustration now. So basically, the tip of laryngoscope should be at the valvulae. You put at the valvulae. Apa maksud valvulae? It's just above epiglottis. When you see epiglottis, you put the tip of laryngoscope above the epiglottis. Alright. Kalau kat sini, this one J, number dia punya alphabet J is epiglottis, right? Betul ke saya cakap? Yes, epiglottis. So above the epiglottis is valvulae. You put the tip of the laryngoscope at the valvulae, and then you elevate about 45 degree. Once you elevate, you can see the inverted V, which is through vocal cord. Alright, this one is a epiglottis. Sorry. And then behind the vocal cord, through vocal cord, is a esophagus. You need to make sure that you insert into the inverted V. It's not the behind the inverted V. Behind inverted V is esophagus. Alright. So this is a step how to intubate. First step is you hold the laryngoscope. You hold on the left side. You guna your left hand. You hold on the left hand, and then you try to push the tongue to the left. Kat sini tak ada lah. Alright, laryngoscope lupa saya nak ambil. Okay, push the tongue to the left in order to give some space on the right side. Okay, and then you go in the midline, insert a bit, and then go to behind the tongue, and then you can see the epiglottis. When you see epiglottis, you put the tip of the laryngoscope in above punya epiglottis, which is at the valvulae. Alright, and then you elevate about 45 degree. Don't use the upper incisor as your panggil apa? Private panggil. You jangan jadikan your upper incisor as a tempat untuk you elevate punya tongue ataupun the upper punya part, the lower part of the to elevate dia punya tongue ataupun epiglottis. Alright. So when you can see dia punya satu false cord which is around the true cord. Dalam ni ada nampak kat dalam tu adalah true cord, which is you can see the inverted V, and then inside the inverted V you can see the laryngeal opening ataupun tracheal ring dalam tu, ataupun nama lain adalah Covet sign. Yang panggil George Covet. Reference is George Covet. Covet sign, when you see the tracheal ring inside the through vocal cord, there is a Covet sign. Covet sign is not good. When you see the Covet sign, you need to depress a bit lah. You need to reduce elevation. You need to reduce the angle a bit until the Covet sign is disappeared. Because of when you have a Covet sign, there is a difficult intubation. Even though you can see the true cord ataupun true vocal cord, but you cannot intubate because of your angulation is more more anterior. So when you put more anterior, so you become difficult to insert the ETT. So you need to make sure the angulation is good, and then make sure the covert sign is not it doesn't appear during intubation. Alright. So this one is a Comet Lehen punya classification. When you intubate, you can see either part of the grade 1 is the whole through vocal cord. You can see there's a grade 1, grade 2. You can see part of the vocal cord, and then you can see epiglottis here. And then grade 3 is you cannot see any vocal cord, but you can see epiglottis. For the grade 4, you cannot see epiglottis. So make sure when you want to intubate, at least you put the cut grade 2, Comet Lehen. Grade 1 is not ideal for intubation. You need to put patient in grade 2, Comet Lehen classification. Alright. Alright, this one grade 1, grade 2, grade 3 sama. This one how you prepare ETT. You need to prepare like this, straight to through cuff, straight to cuff. Basically, straight. This part of ETT should be straight, and then at the distal part of the ETT should be curved about 60 degree. This one is wrong technique. This one is wrong technique. How you prepare the ETT punya ETT equipment. Alright. So this one a failed intubation definition: when you fail after 3 attempts by experienced airway management person, and then inability to maintain saturation more than 90% with bed valve ventilation, mask ventilation. Alright. So if you fail, possible you need to insert the supraglottic device. This one is a supraglottic device, LMA. You can insert LMA as a life-saving punya procedure. Alright. This one I doesn't want to touch more in detail lah basically. I just want to touch in general. LMA you can have a different size depending on patient weight. How you insert ETT, LMA basically you can, I think you can learn during NS posting how you insert LMA. Alright, this one intubating LMA, which is this is a combi tube, I think. It's not combi tube. This one is combi tube. This one intubating LMA. So basically, this LMA is a life-saving procedure. Basically, you can insert either, and then after you insert, you can use this LMA to insert ETT. This is intubating LMA. For this one is combi tube. Combi tube is very life-saving. Is also life-saving device because of you can intubate either inside the esophagus or inside the vocal cord. Inside the vocal cord. So basically, we have a 2 tube here, and then this one is a vented punya tube. When you insert combi tube, when you insert into the esophagus, you need to inflate this balloon and also this balloon, and then the air will come in through this vented ETT and then go into trachea. Basically, when you insert and then ETT is inserted into the esophagus, you can use this vented tube as punya ni lah, how you give the ventilation to the patient through trachea. If you intubate and then insert into trachea, so basically when you insert is what we want lah basically. So it's a when you insert into the trachea, this combi tube, basically the function is as usual punya, as dia punya simple punya ETT lah. Basically when you insert and then the ETT insert into the trachea, basically there is a just like a normal punya ETT. When you insert into the esophagus, there is a function of combi tube lah. You can use this vented tube and then you can ventilate through this vented tube into the trachea. Alright. Okay. Okay, this one is a rapid sequence intubation. Basically, you need to have a preparation, pre-oxygenation, and then you have a pre-treatment. You need to give pre-treatment. Basically, you need to give a fentanyl analgesic, and also some center they give a lidocaine as a pre-treatment. In order to give a mass effect lah, to prevent from sympathetic response. Alright, parasympathetic punya response basically. Alright, and then number 4 is a paralysis and induction. We give the paralytic agent and also induction such as mida, ketamine, propofol. We can give it as an induction. Then give the paralysis. And then number 5 is positioning, which is to make sure we intubate this patient at the correct position, insert into the vocal cord, and then we need to make sure the placement with proof, and then lastly, after you intubate, you need to have a post-intubation management. Okay. So basically, rapid sequence intubation, I think you can learn this RSI during NS posting. Alright? Okay, I think that's all. Yang ni tak apa, yang ni tak perlu ni. If you fail RSI, what you want to do? You have a plan lah basically. Plan A, Plan B, and Plan C, and Plan D. Alright? Okay? I think that's all. Any question? 3:30 dah. Ada soalan ke?
So far so good.
So far okay ya. Nanti yang Airway punya ni, I try to prepare mannequin for you lah. Alright. Okay. If no question, I think let's end our session lah. With tasbih kafarah wa suratul as. Subhanallah wa bihamdika asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Okay, after this you have a class with Dr. Shakur, right?
Yes, Doctor.
Alright. Okay, thank you everyone.
Thank you, Doctor.
Thank you, Doctor.